This one caught me off guard.
Oh, yeah.
We're looking at Chapter 25, Viral Hepatitis. And if you're like me, you probably walked into this thinking you had a handle on the basics. You see the posters in the doctor's office. There are letters involved, A, B, C. And it involves the liver.
That's the standard baseline, right?
Yeah.
Most people just file hepatitis away in their brain as a singular medical event.
Exactly. I thought of it like the flu. You get the flu, you feel terrible, you get better. Maybe there are different strains, but it's basically, the same thing.
Yeah.
But reading through this stack, I realized that treating hepatitis A, B, and C as the same disease is it's wildly inaccurate. It's not just that they're different strains. They are fundamentally different biological entities.
That is the crucial distinction today, right at the start. The term hepatitis is really just a descriptive term.
Yeah.
It means inflammation of the liver. It tells you where the fire is, but it doesn't tell you who started it. And when we talk about the viral alphabet, specifically A, B, and C, though the text does touch on delta and E, we were talking about three completely unique carcinomas.
That's the framework I want to use today. We have 3 suspects. They all target the same building, the liver. They have different methods of breaking in. They cause different amounts of damage. And most importantly, for anyone listening, the way we catch them and the way we get rid of them are polar opposites.
A perfect roadmap. And the stakes are high here. We aren't just talking about a week in bed. We were talking about the difference between a self-limiting annoyance and a lifelong silent killer that can be cancer. Wow. The source material here is dense. It's heavy on serology, transmission vectors, and pharmacology. So our mission really is to decode that clinical complexity for you.
Okay, let's start with the big picture before we interrogate the suspects. The text uses this term hepatotropic viruses. What does that actually mean?
Right. So hepatotropic literally means liver turning or having an affinity for the liver.
Oh.
There are plenty of viruses that can affect the liver as collateral damage like mono or cytomegalovirus, but the ones we're discussing today, the ABC group, they specifically hunt down hepatocytes, the liver cells.
Yeah.
That is their primary target.
And while we have D&E, the text makes it clear that for the vast majority of clinical practice and public health concern, we need to focus on the big 3.
Correct. Delta, or hepatitis D, is kind of a parasite virus. It can only infect you if you already have hepatitis B. And E is rarer in the developed world, though it's certainly a big issue globally. But A, B, and C, they're the ones that shape the entire medical landscape.
Okay, let's bring in suspect number 1, hepatitis A. The text characterizes this one as an acute infection. I've always heard this called the traveler's virus.
That's a very accurate stereotype if we're building a profile. Hepatitis A virus, or HAV, is the hit-and-run artist.
Hit and run, meaning it causes a mess but doesn't stick around.
Precisely. The single most defining clinical feature of hepatitis A is that it does not cause chronic infection. Ever.
Never.
Never. You get exposed, the virus replicates, your body launches this massive counterattack, and the virus is cleared. Completely. Once you recover, you are done. You have lifelong immunity. It doesn't hide in your DNA. It doesn't linger for decades. It hits, and it runs.
But the hit part, reading the symptoms, this is not a gentle tap. This sounds awful.
No, it is physically brutal.
Huh.
But before we get to the symptoms, we have to talk about how it gets in. The transmission route is classified as fecal-oral.
Which is, that's the polite medical way of saying you're eating something contaminated with poop.
It's blunt, but it's accurate. The virus is shed in the stool of an infected person, and it's incredibly resilient. So if someone infected prepares food without washing their hands, or if sewage leaks into a water supply, that virus can easily find a new host.
It really highlights why this is a disease of infrastructure then. The text mentions risk factors like low socioeconomic status, overcrowding, poor sanitation.
It's a marker of societal hygiene. When that barrier between human waste and human sustenance breaks down, Hep A thrives. That's why we see outbreaks in areas with damaged infrastructure, or among populations where hygiene is difficult to maintain, like the homeless population, or within crowded institutions.
The text also flags injection drug users and men who have sex with men as high-risk groups, which I didn't expect for a foodborne illness.
Right, because while we think of it as a food and water issue, it's really about close person-to-person contact. So sexual transmission, particularly where fecal-oral contact is possible, is a significant vector. And for injection drug users, it's often about the sanitary conditions surrounding the drug use itself.
Okay, now here's a biological mechanism that I found absolutely fascinating. The text describes an iceberg effect when it comes to age. It says children under 6 are usually asymptomatic.
Yes, this is one of the most interesting paradoxes of hepatitis A. If you run a daycare center and Hep A gets in, the toddlers might be running around playing, looking completely healthy.
Not a sniffle.
It's not a thing. Meanwhile, the teachers and parents are dropping like flies. They're incredibly sick.
Why? Why does the virus wreck an adult but just leave a kid alone?
It all comes down to the mechanism of injury. See, hepatitis A is not cytopathic, meaning the virus itself isn't the thing blowing up your liver cells.
Wait, really?
The damage is caused by your own immune system.
So the sickness is actually friendly fire.
Exactly. Your immune system detects the virus in the liver cells and launches a scorched earth policy to eradicate it. That inflammation, that destruction of liver cells, that's your body fighting. Children under 6 have an immature immune system. It doesn't launch that massive, overwhelming attack.
So because they don't fight as hard.
They don't get the severe symptoms. But, and this is key, they are still infected. They're still shedding the virus in their stool. They are silent reservoirs of the infection.
That is wild. So the stronger your immune response, the sicker you actually feel.
In this specific case, yes. When a healthy adult gets it, their mature immune system goes to war. And that leads to the classic presentation. Acute onset fatigue, nausea, abdominal pain in the right upper quadrant, right under your ribs.
And the really obvious visual signals, the jaundice.
Right. The liver is so inflamed it stops processing bilirubin, which is a waste product from old red blood cells. When bilirubin builds up in your blood, it turns the skin and the whites of the eyes yellow.
The text also mentioned acolic stools. I had to look that up. It means without bile.
Yes. Normal stool is brown because of bile pigments that the liver produces. If the liver is swollen and angry, it stops secreting bile into the gut. So the stool turns this pale color, like clay or a window putty.
And at the same time, the urine turns dark.
Dark like Coca-Cola, exactly. Because the kidneys are working overtime trying to filter out all that excess bilirubin from the blood.
And the itching. Pruritus.
Oh, the itching can be intense. It's caused by bile salts depositing in the skin. So you have to picture this. You're exhausted, your belly hurts, you're yellow, and you feel like you want to scratch your skin off. It's a miserable experience.
How long does this go on for?
Well, the incubation period is about a month. The average is 28 days. The acute illness itself generally lasts about 2 months. Most people are fully recovered, both clinically and with their lab work back to normal, within about 12 weeks. Almost everyone is better by 6 months.
Okay, so if I'm in the middle of that 2-month nightmare, what do I take? What's the magic pill?
And that is the great frustration of hepatitis A. There is none.
Nothing.
The treatment is purely supportive. Fluids, rest, nutrition. We can give you medicine for the nausea, but we can't kill the virus. We just have to wait for the body to do its job. The text is very clear on this. It explicitly warns against using steroids. You just have to ride the storm.
Which makes the vaccine discussion pretty critical then.
It's the only real defense we have. We have these highly effective vaccines. Havrix and Vocator are mentioned in the chapter. In the U.S., we now vaccinate all children at 1 year of age. And that single policy has just decimated the rates of infection.
And for adults.
For adults traveling to endemic areas, parts of Asia, Africa, South America, getting that shot is non-negotiable.
And what if you miss the shot? Say you find out you ate at a restaurant where a worker was sick, you've been exposed. Is there anything you can do?
There is. We have a window. If we catch it early, during that month-long incubation period, we can give something called immunoglobulin, or IG.
Oh.
It's basically like we're injecting you with a borrowed army of antibodies to help fight the virus before your own system really wakes up. But timing is everything. It has to be given soon after exposure.
Okay, that's suspect 1, hepatitis A. Nasty, spread by poor hygiene, but ultimately it leaves town. Now you have to shift gears completely. Suspect 2, hepatitis B.
The text changes tone here. It feels heavier. It should. Hepatitis B, or HBV, is a completely different beast. For one thing, biologically, it's a DNA virus, unlike A and C, which are RNA viruses. And clinically, this is where we move from acute sickness to chronic threat. This virus is a leading cause of cirrhosis and hepatocellular carcinoma worldwide.
Liver cancer.
Yes, hepatitis B is classified as a carcinogen. It causes cancer.
So how does this one break in? We aren't talking about contaminated food anymore.
No. Hepatitis B is a blood and body fluids virus. It requires a much more direct route into the body.
Like what?
Sexual contact is a major one. Parenteral exposure, which is a broad term for anything that pierces the skin. So shared needles for IV drug use, needle sticks in hospitals, even tattoos or piercings with unsterilized equipment. And the third major route is perinatal transmission.
Carinatal means from mother to baby during birth.
Yes, and globally, that is a massive driver of the epidemic. If a mother has a high viral load when she gives birth, the baby is exposed. And here's the frightening reversal from Hep A, where young kids clear Hep A easily. Newborns are the most vulnerable to Hep B. If a newborn gets infected with Hep B, there is a 90% chance it will become a chronic, lifelong infection.
90%.
90. Their immune system is too immature to fight it off, so the virus just sets up a permanent residence in their liver cells for life.
The text outlines the phases of infection: incubation, a symptomatic phase, and then this thing called seroconversion. This sounds like the fork in the road.
It is. Seroconversion is when the body tries to fight it off and develop antibodies. In healthy adults who get Hep B, most will clear it. They go through that acute phase, they feel sick, but their immune system wins and they come out the other side immune.
But not everyone.
But for a percentage of adults and for that huge percentage of babies we just mentioned, the immune system fails to clear the virus, and that's when it becomes chronic. If you have the virus detectable in your blood for more than 6 months, you have chronic hepatitis B.
Okay, I want to pause here. Because to really understand hepatitis B, you have to understand the diagnosis. And frankly, looking at Table 25-4 in our source material, I felt like I needed a degree in hieroglyphics, HBsAg, anti-HBs, anti-HBc, IgM, IgG. It's an alphabet soup within the viral alphabet.
It is notoriously confusing, even for medical students. It's probably the most common thing people get wrong. But we can decode it. You just need the right analogy.
Please, help us out.
Okay, let's visualize a house. Your body is the house. We have 3 main characters to watch for in the blood test.
Okay.
First, there is the HBsAg, the surface antigen. Think of the antigen as the burglar. He's the actual virus, or at least a piece of his code.
The burglar. Got it.
So if your blood test comes back HBsAg positive, it means the burglar is in the house. You are currently infected.
Okay. Antigen positive burglar is present. I'm infected. Simple enough.
Exactly. A second character is anti-HB, the surface antibody. Think of the antibody as the police.
Yeah.
Their job is to find the burglar, handcuff him, and kick him out.
The police. Okay.
So if your test says surface antibody positive, it means the police are in the house.
So if the police are there, that usually means the burglar is gone.
Usually, yes.
Yeah.
If you have the antibody, the police, and you're negative for the antigen, the burglar, you're immune. You are safe. But, and here's the million-dollar question, how did the police get there?
What do you mean?
Did they come because there was an actual robbery in the past, or were they hired as private security beforehand just in case?
You mean from a real infection versus a vaccine? Better tell the difference.
As our third character, anti-HBC, the core antibody.
Yeah.
Think of the core antibody as a broken window.
A broken window?
When the real virus, the burglar, breaks into your house, he smashes a window to get in. That broken window stays there forever as evidence that a crime took place. The vaccine, however, doesn't break a window. The vaccine is like giving the police a key. They enter peacefully to stand guard. No damage done.
This is brilliant. Okay, let me try to apply this. So scenario A, I test positive for the surface antibody of the police. And the core antibody, the broken window.
What does that tell you?
The burglar broke in, smashed the window, but the police showed up and got rid of him. I had a natural infection and recovered. I'm immune.
Perfect. Now, scenario B, I test positive for the surface antibody. The police are there, but negative for the core antibody. No broken window.
The police were let in with a key. The burglar was never there. I am vaccinated.
Exactly.
Yeah.
You see? And the last one, scenario C, I am positive for the antigen. The burglar is in the house. And it's been that way for more than 6 months.
The burglar has moved in. The police either didn't show up or they weren't strong enough to kick him out. I have chronic hepatitis B.
You got it. That's the whole table decoded. The core tells you the history of violence. The surface tells you the current status of the war.
There was one other little piece, the IgM.
Ah, right. One tiny nuance. If you see IgM anti-HBC, think of IgM as the SWAT team. They only show up during the active full-blown emergency. So if you see IgM, it's an acute infection happening right now. If it's the other kind, IgG, that's just the old broken window from the past.
Yeah. Okay. That makes so much more sense. So let's talk about the people who have the burglar living on the couch permanently, the chronic patients. What does their life look like?
Well, it's a spectrum. Some people are what we call healthy carriers. The virus is there, but the liver is functioning pretty well, and they feel fine for a long time. But the virus is still there. It's DNA integrated into their cells, potentially causing this low-level, smoldering inflammation.
And for others?
For others, they have active chronic hepatitis. They have fatigue, pain, and their liver is slowly, year by year, turning into scar tissue. That's called cirrhosis.
The text gives a pretty scary statistic on that. It says 20% of patients with cirrhosis will develop decompensated cirrhosis within 5 years. What does decompensated mean?
Decompensated means the liver has failed. It can't do its jobs anymore.
Which
It can't filter toxins from the blood, so you get confused and disoriented. That's encephalopathy. It can't make the proteins that hold fluid in your blood vessels so your belly and legs fill with water. That's ascites. And you can't make clotting factors, so you bleed very easily. It is a horrific way to decline.
So we treat it. But the text suggests the goal isn't necessarily a cure like we think of with an antibiotic.
Right, because Hep B integrates its DNA right into our own DNA. It is very, very hard to fully eradicate. So the goal for most patients is suppression. We want to hammer the viral load down so low that it can't damage the liver or cause cancer. We want to put the burglar in chains in the basement.
What are the weapons for that?
We have a couple of main classes. There are immune modulators like interferon, which basically tries to boost the body's own police force. But more commonly now, we use oral antivirals. The text lists entecavir and tenofovir. These are nucleoside analogs. They're essentially fake building blocks that stop the burglar from being able to clone himself.
But you have to keep taking them.
Often, yes. Indefinitely. It's like taking medication for high blood pressure or diabetes. You take it every day to keep the disaster at bay.
Which brings us right back around to prevention. If we can't easily cure it, we really, really need to prevent it.
And we can. The hepatitis B vaccine is one of the greatest achievements in modern medicine. You have to think about it this way. It is effectively the world's first anti-cancer vaccine.
Wow, that's a powerful way to frame it.
It's true. By preventing the virus, we prevent the liver cancer it causes decades down the line. It's recommended for all infants, for adolescents, and for any high-risk adult. If you work in healthcare, if you're on dialysis, if you have multiple sexual partners, you need that police force installed and ready to go.
Okay, so we've covered the hit and run, which is Hep A, and the burglar, who might move in for good, Hep B. Now we reach the third letter, hepatitis C. The chapter calls this one the silent epidemic.
And that's exactly what it is.
This one scared me the most in the reading. With Hep A, 0% of people become chronic. With Hep B, most healthy adults clear it. But with hepatitis C, the text says up to 85% of acute infections become chronic.
That is a headline number, and it's staggering. Hepatitis C is the master of persistence. If you catch this virus, the overwhelming odds are that your body will not be able to clear it on its own. It is almost guaranteed to set up shop for life.
Why? Why is our body so bad at fighting this one virus?
The shapeshifter. Hepatitis C is an RNA virus with an incredibly high mutation rate. So every time your immune system creates an antibody, a police officer, to lock onto it, the virus changes its coat just enough to escape. It's constantly staying one step ahead.
So it's like the police have a wanted poster, but the suspect keeps changing his face.
A perfect analogy. And because it's silent, people don't even know they're losing the war.
What do you mean?
Acute Hep C is rarely dramatic. You might feel a little tired, maybe have what you think is a flu that lingers for a bit, but you usually don't turn yellow. You don't end up in the ER, so you ignore it. And all the while, the virus is quietly scarring your liver year after year for 20 or 30 years.
This connects directly to the boomer alert mentioned in the text. The CDC recommends a one-time screening for everyone born between 1945 and 1965. Why that specific group of people?
It's a tragedy of medical history, really. We didn't even identify the hepatitis C virus until 1989, and we didn't have a good screening test for the blood supply until 1992.
Before 1992?
Right. Before 1992, if you received a blood transfusion for any reason, there was a risk. So the boomer generation, who were in their prime during the 60s, 70s, and 80s, they might have had a transfusion during a surgery, or maybe experimented with injection drugs, even just once, during an era when we didn't even know this virus existed.
So someone could be walking around today, a grandparent, retired, feeling totally fine, but they've been carrying this virus since a car accident in 1981.
Exactly. And now, 40-plus years later, the cumulative liver damage is reaching the tipping point. That's why the screening is so vital. You have to go find the virus, because it won't announce itself until the liver is already failing.
The primary transmission today, though, it's mostly injection drug use.
Yes. It is incredibly efficient at spreading through shared needles and other contaminated equipment. It's much less efficiently spread through sex than Hep B is, but blood-to-blood contact is the absolute superhighway for hepatitis C.
Now, unlike Hep B, where we often settle for suppression, the text says the goal for Hep C is eradication. We actually want to cure it.
This is the good news in the story. Because hep C is an RNA virus, and it doesn't integrate into our DNA in the cell nucleus like hep B does, we can kill it completely. We can scour every last copy from the body.
But it's not as simple as taking a penicillin pill for a week. The text talks about genotypes.
Right. Because it's a shapeshifter, over time it has evolved into different families or genotypes, genotype 1, 2, 3, 4, and so on. You have to know which one you are fighting to choose the right weapons.
The source material describes a standard of care for treatment that sounds intense. It mentions triple therapy for genotype 1.
Yes, and this reflects the era of treatment described in the text. It involves a combination of pegylated interferon, a drug called ribavirin, and a new class at the time called protease inhibitors like boceprevir or teriparavir.
Okay, let's break that down. Interferon. It sounds like some kind of sci-fi shield, but when I read the side effects section, it sounds more like chemotherapy.
It is brutal.
Mm.
Interferon basically revs up your entire immune system to a fever pitch. Imagine the worst flu you've ever had. The high fever, the shaking chills, the terrible muscle aches. Now imagine inducing that feeling on purpose with an injection every single week for 48 weeks.
A full year of the flu.
A year of feeling sick. And that's just the physical side. The text is very clear about the neuropsychiatric effects. It can cause severe depression, crippling anxiety, insomnia, irritability. Patients on interferon would describe feeling like they were losing their minds. It causes distinct chemical changes in the brain.
And ribavirin isn't a walk in the park either, right?
No. Its main side effect is that it attacks red blood cells, causing anemia. So on top of everything else, you are profoundly exhausted from the anemia, you're shaking from the interferon, and you're depressed from the chemical imbalance it's causing in your brain.
Wow. It really puts that 80-80 rule into perspective. The text says patients need to take at least 80% of their medication for 80% of the duration to have the best chance at a cure.
And now you can see why that's so incredibly hard. When you feel that sick every single day, the temptation to skip a dose is enormous. But if you skip, you give the virus a chance to mutate and become resistant to the drugs.
So adherence is the whole battleground.
It is. The medical team isn't just prescribing pills, they are coaching the patient through a psychological and physical marathon that lasts for months and months.
And we have to do all this because there is no vaccine.
Correct. The very same reason the body can't cure it, that shame-shifting ability, is the same reason we can't make a vaccine for it. It's impossible to make a stable wanted poster for the immune system if the suspect changes his face every single day.
So for hep C, treatment is prevention. If we cure people, they can't spread it to others.
Exactly. We call that treatment as prevention, and it's a cornerstone of public health strategy for HCV.
This has been an incredible tour of this viral alphabet. I feel like I finally understand why these are 3 completely distinct files. Let's try to synthesize this into a cheat sheet for the listener. If they take away one summary for each letter, what should it be?
Okay, let's boil it all down.
Hepatitis A.
Hepatitis A, the identity, the acute intruder, the vector, fecal oral. Think food, water, hygiene, the outcome. It's a classic hit and run. You get sick, you clear it, you're immune for life, no chronic state. The defense, vaccine exists, and wash your hands.
Okay. Hepatitis B.
Hepatitis B, the identity, the complex DNA virus, the permanent burglar, the vector, body fluids, sex, measles, and mother to child at birth. The outcome can be acute or chronic. The burglar might move in for good, high risk of liver cancer. The defense. The vaccine is the gold standard. It's an anti-cancer vaccine. For those who are chronic, treatment is lifelong suppression.
And finally, hepatitis C.
Hepatitis C, the identity, the silent shapeshifter, the vector, primarily blood, IV drug use, and blood transfusions before 1992. The outcome, the silent epidemic. Up to 85% of people who get it become chronic. The defense, there's no vaccine. But we can cure it with treatment eradication is the goal, provided you can withstand that grueling regimen.
That is crystal clear. It really changes how you assess risk in your own life, doesn't it? If you're traveling to a region with questionable water quality, you're thinking A. If you're a nurse handling needles, you're thinking B. If you're a baby boomer who had surgery back in 1980, you really need to be thinking about C.
Precisely. That knowledge allows you to categorize the risk and take the right precautions.
Before we close the file, is there one final thought that sticks with you from this deep dive? Something for people to really sit with?
I think it's the concept of silence.
Silence.
Yeah. In medicine, we are trained to react to noise, to pain, to bleeding, to a high fever. Patients come to us when they hurt. But the true monsters in this chapter, chronic hep B and chronic hep C, are silent killers. They rely on our ignorance. They rely on the fact that the liver is a very, very stoic organ. It doesn't complain until it is almost completely destroyed. We have the tools. We have the vaccines for A and B. We have the cure for C. But those tools are completely useless if you wait for the virus to announce itself. The burden is on us, on patients and doctors, to break the silence. If you fit one of those risk profiles we talked about, especially that birth cohort of 1945 to 1965, do not wait for a symptom. Go ask for the test.
Because the virus won't tell you it's there until it's already too late. You have to go find it. That is a powerful takeaway. Thank you for helping us decode the alphabet today.
My pleasure.
To our listeners, stay curious, stay proactive with your health, and please wash your hands. We'll see you in the next deep dive.